Good morning. Hi, it's Babak, Larian, doing a session of Facebook Live Q&A on parathyroid disease. So we have a lot of questions, fortunately, that have come in. So I'm going to try to go through the questions. I'm sorry the podcast got delayed. I had something to do, but we're gonna start now, and I'll try to get through as many questions as possible, and hopefully help as many people as I can. Hope you guys are staying safe, healthy, well informed, and making your own decisions about how to deal with these crazy times, wherever you are in the world. My best wishes to all of you. All right. Okay. So let me see the first question. All right. So the first question asks, this is Kelly. Good morning, Kelly. The first question is, I can't remember if you discussed this before. If ionized calcium is a more accurate measurement of calcium rather than serum calcium, I know you've talked about how a lot of times the machines used to test the ionized calcium are not accurate, but if they are properly calibrated, would it be a truer look at calcium levels in your body? As always, many thanks. Very good question, Kelly. Let me explain. Hold on. Let me turn you around. Okay. So, actually, let me see if I can get you to the calcium. There you go. So, calcium exists in many forms in the body, right? It can be free floating, right? Like this part. These calciums are free floating in the blood vessel. There's some that attach to a protein called albumin, like this. And there's some that are attached to other chemicals, phosphate, citrate, right? Those that are attached don't do anything. They're not able to go in and out of the blood vessels and go into the cells and perform functions. So the true representation of a useful, serviceable calcium is what's free floating, right? This is what's biologically active. And this is what ionized calcium looks at, right? Now, the reason there's a difference between regular calcium level and that is that, let's say you have a calcium of 10, right? And there's 22 calciums in this picture, right? And 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, exactly half are attached and half are free floating, right? So if you have a calcium of 10, and this is what the blood composition looks like, 5 of those calciums are free floating, right? On the other hand, if you have a calcium of 10, but you only have this many albumins, 2 rather than 3, and so instead you have 1, 2, 3, 4, 5, 6, 7, 8 calciums attached of the 22 and 14 free, then you have, even though your total calcium is 10 here and here, in this picture, the level of free ionized calcium is significantly higher, right? And that's why you have a formula of corrected calcium based on albumin, right? That formula gives you a relatively good number, but it doesn't take into account those components that are attached to other things besides albumin. Now, those components are only 5%, so when you do this calculation, you're off by roughly 5%, right? But that's a close enough number where it can give you a fair picture. So either getting the albumin, doing the calculation, and getting the corrected calcium level, or getting ionized. And the ionized, yes, the ionized is the dose that it's the amount of calcium in your bloodstream that's actually working and doing the functional work. And so what you're saying, Kelly, is absolutely true. The problem is that the machines to check ionized calcium are very sensitive machines. in the hospitals, those machines are being used constantly in the operating room and the emergency room because they need to, the ionized machine actually is a rapid machine, so it gives you a number very quickly. So in the operating room, when they want to check someone's calcium levels, they do the ionized calcium, and immediately they can get a result, so they can adjust the person's calcium level in the operating room. Or in the hospital setting, when emergencies happen, cardiac arrests happen and they have to give calcium, all sorts of events in a hospital or emergency room that require you to have a machine that's precise and gives you an answer. So those machines are constantly being used and constantly being calibrated. In a laboratory setting, most of the time the laboratory is getting regular calcium levels. It's very infrequent that they get ionized calcium levels. And because of that infrequency, the machines are not necessarily as calibrated, as precise, because the utility is not the same. And so what I try to do is I actually try to get both albumin levels and ionized calcium levels, and try to kind of get a picture of the whole thing. If the albumin levels are in the normal range, right? If the albumin level is 4, right here, right? If the albumin is exactly 4, then your calcium level in your bloodstream is exactly normal, because then the calculation is 4 minus albumin level, so 4 minus 4 would make it 0 times 0.8, 0 plus serum calcium, right? So if your calcium is 4, right? So, and your blood level is 9.5, it's going to stay 9.5. If your calcium is, let's see, if calcium is let's say your calcium is 5. Your calcium is 10 in your blood. Your albumin level is really high, right? At 5, right? So that's negative 1 times 0.8, negative 0.8. Your calcium is 9.5 in your bloodstream, but when you make the calculation, it tells you that your calcium is 8.7 because it's negative 0.8, right? On the other hand, if your calcium is 9.5, your albumin is very low, right? Right? Let's say your albumin is 2.5. You're really malnourished, you're not eating well, your albumin is 2, right? So 4 minus 2 is 2 times 1.2 times 0.8, 1.6. So if your calcium is 9.5, your albumin is 2, then you're adding 1.6 to the 9.5. Your calcium is almost 11.1, right? So the number of albumin matters, right? And 11.5 being 5% off because of the phosphate and the citrate that's not being put into the calculation, right? Okay, so instead of 11.1, you're 11. It still is a high number. So that's why corrected calcium is meaningful when your albumin is not close to the normal range amount, right? And it gives you a true sense also. So when you don't have access to ionized calcium, getting an albumin level is generally a good idea and a good substitute, right? And it doesn't have the reliance on a machine that's being constantly calibrated. All right, let's go to the next question. Mag Wilson. Dr. Hunt, could you tell me how often after surgery we need levels checked? My endocrinologist only told my GP to check my calcium level. I thought I would need calcium and PTH done at the same time to be certain. I'm like, you're 100% right. You're 100% right, Max. Sorry, I forgot your name. Doing calcium alone is not meaningful. It's just not meaningful at all on its own. As you guys who've watched this before, calcium levels, and just like you saw, the calcium levels are subject to many different things in the bloodstream, right? The protein levels, the albumin level, phosphate, citrate. So those things may have an impact. But also, it's comparison of your calcium to what you had before and comparison of your PTH to what you had before, right? Because without checking the calcium, PTH, and vitamin D, you're not going to know the true status of the whole system, right? You didn't do parathyroid surgery to only correct your calcium. You did parathyroid surgery to get the hormonal system back into balance, right? And PTH is a hormone. Vitamin D is also a hormone, right? And so those two things also have an impact on the calcium level, right? And so looking at the whole thing is important. I generally check for patients who have hyperparathyroidism due to a parathyroid adenoma. I check calcium, PTH, and vitamin D at 1 month, and if that's normal, again at 6 months. If it's not normal, depending on the degree of abnormality, I may check it again at 2 or 3 months after surgery. In people who have parathyroid hyperplasia and have removed 3 glands or 3.5 glands, I generally check calcium levels 1 week after surgery, 1 month after surgery, and 6 months. And again, that's generality. I make adjustments according to what I find, okay? So, moving on to the next question. Let's spin out ourselves. Debbie. Morning, Dr. Larian. I have hyperplasia, 3 glands removed 2 years ago. I still feel that I have all the symptoms. My blood tests in June were calcium of 2.33, adjusted to 2.34, well done. PTH is 8.2 elevated, so calcium is in the mid-range and PTH is elevated. Vitamin D is close to the lower end of normal for you, 69. Thank you for including the range, by the way. This is really helpful because I can have a more meaningful conversation. GFR is 85, so slightly low, which can in and of itself increase PTH levels. And chlorine is 110. I had a kidney CT/CT, my stones have grown, they haven't. However, I have 12 millimeter right lower pole simple renal cyst and a right adrenal nodule. I've been discharged from the joint endocrinology urology clinic with no explanation from the consultants. I supplement vitamin D 3,000 units and K2 also magnesium. Good job. Is the adrenal nodule to be hyperplasia, and do I need to do anything? You know, the adrenal nodule, Debbie, thank you again for putting the reference ranges so I can actually have a more meaningful conversation and help you. The adrenal nodule is only meaningful if there is a hormonal impact. So if they check the hormones produced by the adrenal glands and they are being impacted by the nodule, either elevated or low or so on, then the nodule may be addressed, right? Otherwise, if the nodule looks benign, then maybe a follow-up scan in a few years would be what's necessary, right? If their degree of suspicion for it being a cancer is low. To have some degree of suspicion, obviously a sooner assessment would be necessary. In terms of your calcium and PTH numbers, listen, if you would please send me, Debbie, your pre-operative calcium, PTH, and vitamin D levels, right? And let me look at that. Let me see how the numbers are different, or the numbers you've had over the past year, because if the numbers are significantly different than pre-op, and your GFR, which is called the glomerular filtration rate, right? That's even a hard thing to say. Glomerular. Anyway, that signifies, GFR signifies how much your kidney is working, how well it's working, and how much output it has, right? When the output of the kidney goes down, it's partly involved with filtration of PTH, and the PTH levels go up, calcium levels may go up as well, because the kidney filters the calcium. So, you know, diminished functionality of the kidney is a factor in all this, right? So I think looking at those numbers over time is meaningful, right? Because if your calcium is roughly the same and your PTH is roughly the same, then that means that your fourth gland is still a part of the hyperplasia and overactive now and may need to be addressed, right? If, on the other hand, your calcium is significantly lower, but your PTH is staying high, that may mean either the functionality of the kidneys having an impact, or you are not taking an adequate amount of calcium in your diet, right? So your parathyroid gland is working hard, and the PTH being high, in and of itself, PTH can give symptoms, and it could be that your symptoms are related to that PTH, okay? So I think looking at the historical numbers would be very helpful in figuring out where you are and what you should do. All right, let's turn around. I'll look at the next question. Allison. Hi there. Hi there, Allison. Thank you. My pleasure. I'm happy to take your question. I am 2 years post-op after surgery for normal hormonal hyperparathyroidism. One adenoma removed. I continue to have symptoms. Of course, you and I have spoken many times. Deep bone pain in my legs, excruciating at times, brain fog and fatigue, among other symptoms. My blood work is in the normal range, and PTH is low 40s. Vitamin D 35 to 40. My ionized calcium is always at the very top of the range. My question is, how does ionized calcium scores factor in the overall picture of hyperparathyroidism? I have another observation that when my bone pain is particularly bad, often my urine is very cloudy. Is there a correlation between this? Thank you so much. Allison, you're an amazingly observant person and intelligent, and it's truly a tragedy to see you going through all this, and it's hard to watch because it's hard to figure out what's going on with you at times. If your ionized calcium is on top of the normal range, 5.3, right? And your PTH is in the low 40s but doesn't go down, it seems like that's a overactivity of the remaining parathyroids, right? And again, if one gland was removed, it's not clear if that gland is an adenoma or an asymmetrically hyperplastic parathyroid, right? So let me go through that. That may not seem intuitive, but let me try to explain. So parathyroid hyperplasia is a beast, I would say, because even though we have an imagination that when someone has hyperplasia, they have 4 perfectly enlarged parathyroids, and that does happen when people have kidney failure. They can have very large parathyroids. In most people who have hyperplasia, their hyperplasia is asymmetric, and you can see that in this picture. 4 very different sized glands, 3 that clearly look abnormal, and 1 that looks, in terms of coloration, abnormal, but in terms of size and shape and conformity, not necessarily abnormal, right? And so this asymmetry is what exists. Now, if you have this asymmetry and you have a really big one and the other 3 are much smaller, when this is taken out, your PTH can drop because this one is so much more active than the other 3. And on a radio-guided surgery, these less active glands may seem not to be active enough to need to be removed, and so on. And so you may have a surgery that fails, essentially, because you're dealing with asymmetric hyperplasia, and asymmetric hyperplasia is challenging because it's hard to get a handle on with any of the techniques that we have, and it really is the surgeon's experience that really oftentimes helps the patient, and I would say in the hands of expert surgeons, most of the time when they have a failure, it is because of this asymmetry that exists in hyperplasia, okay? At least in my hands, that's what I found my failures are mostly due to. And so I've always thought that you are the person who potentially may have this condition, but I couldn't be sure, because your numbers are so variable. They sometimes look like hyperparathyroidism, and some of the numbers you've had that I've reviewed with you do not look like that, and it makes it hard because you're not doing so well, because you're having so many symptoms and you're suffering so much. And so it is concerning. You know, one of the things that alarms me about your case is the fact that your ionized calciums have run high most of the time, and your PTHs are running in the 40s. You know, the problem is that both of those numbers are in the normal range, right? And in those particular cases, you try to look at the relationship, and yes, your relationship seems to be that your calcium runs high normal and your PTH runs low normal, or mid-range normal, and it's confusing because you have all the symptoms that could go along with it. And so again, it creates a tough situation because it puts you in a position where you don't have a clear answer to know if a second surgery is going to help you, and for a surgeon, for me to tell you with any degree of conviction, you know, especially because the scans we've done have not been fruitful, that where you stand with it, right? So very tough situation, and I think about you often, and you know, yeah, you're kind of on the back of my mind at all times. I hope this conversation helps. I know, I have a feeling that someday you will figure out, you're going to call me and say, this is definitely parathyroid, we need to do the surgery, or definitely I found the reason, this is this other issue, and it secondarily was affecting my calcium balance and so on. But I'm certain you will figure it out. You're certainly intelligent enough to be able to do it. I have faith in you. All right, Michaela Shapani, I'd like to know what role, if any, hyperparathyroidism plays in platelet counts. Mine tend to be at the low end, but many with hyperparathyroidism tend to have high levels. Is there any association? Michaela, not that I've read. I mean, there could be, but I haven't read anything, and I haven't seen a particular trend with my patients of having either low or high levels. Now, in patients who have severe hyperparathyroidism, and their calcium levels are really high, they tend to have a little bit of a dehydration issue, and that can cause concentration of platelets in the bloodstream, but it's not because they have more platelets, but rather they have less volume of blood. And that could be it. But I really haven't seen it as in general in most people who are not hospitalized for hyperparathyroidism as an association. But something to look into. I'll make a notation. Okay, moving on, Jackie. Hi, Jackie. Hi, Dr. Larian. I hope that you're keeping well. What is the largest hyperplastic parathyroid glands that you have removed? Thank you generously. My pleasure, Jackie. Hyperplastic. Probably the largest. Jackie, let me first preface that the size of the hyperplastic lesions is affected by the condition that causes the hyperplasia, right? So when in patients who have a genetic base to their hyperplasia, that they've been born with it and it grows all their life, they're not tremendously big. So the largest one I would say that I've removed is roughly 1.8 to 2 centimeters, right? But in patients who've had kidney failure and they have parathyroid hyperplasia, I've taken out 4 centimeter parathyroids. They can grow to be very, very large. Massive. So 4 centimeter for kidney patients, and it's 1.8, 1.5, between 1.5 and 2 centimeter is probably the largest size that I've seen in a non-kidney patient that have had hyperplasia, and I knew that they had hyperplasia, right? It's possible that I've taken out an hyperplasia gland that was disproportionately big, thinking it was an adenoma, and either the patient got better and then, it's taken years for the other glands to start overworking and the patient has not felt it, or they said, Dr. Larian is a quack, I'm going to go see another surgeon because he took one out and I'm still not feeling good, and another surgeon knows that that's what happened to me. In any case, any possibility is there, but I think The generality is that the hyperplasia glands that are from genetic base tend to not be very large to have a deep impact, and in terms of kidney failures, they can grow to be very large because once the kidney stops working, there is no activation of vitamin D, and vitamin D suppresses the parathyroid glands, and then the thing goes wild and grows as big as it can. And thank you, Kathy. Kathy just texted that you're definitely not a quack. I appreciate that. Moving on. I hope that answered you. Sally Harling. Thank you so much for your time. I'm in the UK. Hi, Sally. I had an adenoma removed last May. I was normal calciumic. My calcium and PTH dropped post-surgery. Early this year, I started feeling unwell again. Blood showed PTH 8.6 elevated, 6.8 is the upper limit of normal, and calcium 2.3, and vitamin D 47. I started taking more vitamin D, magnesium, boron, and recent results show PTH again 8.3, calcium now 2.27, just slightly lower from 2.3, and vitamin D is 75, significantly higher. GP says it's secondary as my PTH has come down. I'm getting horrific bone pain again, which is getting worse, and brain fog. I've had one of our consultants on the medical group run by Sally JP offer his opinion, and I have had a referral now to him. What am I expecting to find? Listen, you've corrected your vitamin D. Your calcium and PTH only went down by a slight amount. You still look to me to have a normal calciumic hyperparathyroidism. Unfortunately, that's what I have to say. And Sally goes on to say that she's struggling to maintain vitamin D levels without supplementation. And she's supplementing everything. B12, ferritin levels are low, on the low side, and supplementing magnesium. And she's been doing it for 4 months, and you supplement it for 4 months. There is minimal change in your numbers. Again, if by taking the vitamin D and all the supplements you had taken, your calcium will go from 2.3 to 2.27, great. But your PTH dropped from 8.6 that you had originally to 5, right? Goes well within the normal range, and I would say yes, definitely you're secondary, right? But that's not what's happened. It's gone from 8.6 to 8.3. That's not a significant enough change in PTH. In fact, I would say that if you were to check your PTH levels 3 times today, you probably would get that change in PTH level from 8.6 to 8.3, or in fact from 8.3 back up to 8.5, 8.6, it went 8.7 as a routine, not as an indication that there's been measurable gains, okay? So I think, unfortunately, Sally, you may be still dealing with normal calciumic hyperparathyroidism. I would look at your calcium levels before and to see before your surgery, what were your calcium levels. I'm sure you know those numbers. If those calcium numbers are similar to what you have now, and your PTH level is elevated, and your vitamin D has normalized after 4 months of supplementation, then I don't see anything else besides a recurrence, unfortunately. All right, moving on to Heather James. Hello, Dr. Larian. Thank you so much for your time with us today. I had a question regarding bone spurs and vertebrae issues. Let's see. Can these two things cause bone spurring, and if so, can bone spurs go over time after successful? Bone spurs, I don't think bone spurs develop as a consequence of hyperparathyroidism. I think they develop as a consequence of trauma and continued pressure on the bone. and I don't think treating a hyperparathyroidism, unfortunately, takes them away. I wish it would. That would be ideal. Okay, let's look at the next question. Sorry, let me flip you out. Abigail Baker Arbery. Thoughts, experience on parathyroid cysts, how they present, how common, treatment. Well, parathyroid cysts are, I'd say I'd see them maybe in about 5% of the patients that I operate on. In and of themselves, they don't cause any problem. I see them disproportionately in abnormal parathyroid glands, right? So when they're producing a lot, they're overactive and working hard, they tend to produce fluid-filled sacs within them more. But having a cyst with a normal parathyroid function does not require a surgery to remove the cyst, or in fact, it doesn't require any treatment. The cyst has to get very big, right? And the largest cyst I've personally seen has been maybe 2 centimeters, right? But they'd have to get significantly larger than 2 centimeters to start putting pressure on the surrounding tissue to be a problem. So if you have a small cyst and your parathyroid hormone levels and calcium levels and vitamin D levels are all normal and you're feeling fine, that does not require any intervention. Potentially maybe ultrasound observation and continuing to look at your blood test to make sure that it's not in the process of becoming abnormal, but that's about all you would need to do. You don't need to treat a cyst in and of itself. All right. LaBelle Jupiter. Hello. I hope I didn't massacre your name. What do you do when a patient with hyperplasia and only half a parathyroid gland left starts having symptoms again? It all depends on what is the surgery that they had originally, and let me explain. So, there's 2 ways to address hyperplasia, right? So, either doing a 4-gland parathyroidectomy with autotransplantation of one of the glands. So you take the smaller gland, cut it in half, right? And then chop it up into little pieces, right? And insert those little pieces in the muscle, right? That's one way of doing it. The other way is either to remove 3.5 glands or 3 glands. In your case, the 3.5 glands, right? Now, if they do the 3.5 glands, but they leave that 3rd gland in place instead of auto-transplanting it, right? So that would be similar to this. These are the steps of the surgery, right? This person has 2 enlarged parathyroids, a 3rd enlarged parathyroid, the 4th one is not so enlarged. So in this particular case, what I would do is take the 2 on the left side that are enlarged, take the upper one on the right that's enlarged, and leave the lower one in its place with a metal clip, a titanium clip, to mark it, right? And I would probably transpose or move it so that it's sitting away from the nerve to the voice box. I would probably suture it to the site of the breathing tube so it's farther away, and check PTHs during the surgery to make sure that it is functioning still properly after I've done all that. And so if that's the case, if I now have this parathyroid that was originally here, right, and now I've sutured it up there, dry it and white, I've sutured it up there so it's away from the nerve here and closer to the skin, I would go back, find it, and see if I can still cut it down a little bit more and maintain adequate functioning. Because all we're doing all we're doing with parathyroid hyperplasia surgery is reducing the number of abnormal cells, right? I don't know of a way of curing someone who has parathyroid hyperplasia and hyperparathyroidism without causing them to become hypoparathyroid, right? So you either cure them by removing all the parathyroids, in which case you've changed hyperparathyroidism with hypoparathyroidism, or you reduce the number of abnormal cells, hoping that you've reduced them enough to not overfunction and have adequate enough numbers to appropriately function, and have guesstimated appropriately so you have bought enough time in their lifetime so that it doesn't have an opportunity to grow enough in their lifetime to give them trouble. A lot of guesstimation, a lot of conjecture and guessing and trying to figure things out, right? And that's how I do it, because the reason I don't do the autotransplantation is first because autotransplantation works 80% of the time and it doesn't work 20% of the time. So 20% chance of not functioning is too high, right? And so I try to do everything I can to prevent that possibility. It happens, but it's something that obviously, as a parathyroid surgeon, I do everything I can to try to prevent that, right? And just like all other things with surgery, I'm getting better at it, and I'm sure experienced surgeons will tell you the same. They are getting better at prevention and so on, right? But if you autotransplant, the second problem with that is that once the autotransplanted material in a muscle grows and starts overfunctioning, because it's not a discrete thing, I can't go in there and remove a portion of it because it's inside embedded in the muscle, right? So what I would have to do is basically remove that portion of the muscle, in the process removing the entire remaining parathyroid that was autotransplanted, and therefore that person would have permanent hypoparathyroidism, right? So if there's autotransplantation, there's no choice besides permanent hypoparathyroidism. If that person has a portion of it left in place with blood vessels intact, right? Again, let me flip you around. So if in this scenario, I'll magnify, let's say, right? If in this scenario, I'll draw it here. I'll draw the parathyroid in pink, right? Let's say this is a slightly enlarged parathyroid, that one I left behind. And it has a blood vessel going into it and a blood vessel coming out of it. And during surgery, I had just biopsied a portion of it. Let's do it in white. And put a metal clip there during the first surgery. During the surgery, I come back and try to find this and see if I can maintain these blood vessels and cut a little bit more, right? So I can reduce the number. So let's say the gland had over time gotten bigger, like this, right? Then I would come in and try to cut it down again to make it much smaller and remove this portion, right? That would be the idea. That's the possibility if you keep the gland in situ, right? If you go in there and you find that there's too much scarring and you can't do that, then you still have the option of removing a portion, cutting it up into little pieces and inserting it in the muscle. So you have two options that has been left open for you. So that's the way I choose to do it. Hopefully that's what you had, Lisa, and that you can go ahead and do that. I'm sorry, LaBelle. Hopefully that's what you have and that's what you can do. Okay, moving on to Lisa. Hello, Dr. Larian. What can you advise a patient with hyperplasia and hyperplastic right thyroid nodule, had a double parathyroidectomy, no relief from symptoms, post-op with normal range calcium and well above normal range PTH, whose symptoms have been dismissed as menopause? I was told post-op follow-up that the surgeon felt there were signs of growth on a third gland. Lately, 2 years post-op, I can't get anyone to agree to a scan to see how the hyperplasia is progressing. I have a complex family history, including relatives who have had parathyroid surgery and dying of brain tumors, currently undergoing genetic testing. Okay, so genetic testing is very important for you, obviously. It's more important, obviously, to as an information for both you, your relatives, potentially your children, if you have any, all right, for them to know and be aware. But in your particular case, I would say, if your numbers are abnormal, then you have hyperparathyroidism. If your PTH levels are still elevated, your calcium is still normal calcemic, your vitamin Ds are normal, you do a 24-hour urine calcium, and you don't have, you have normal or elevated calcium in your urine, you don't have a diminished calcium level in your urine, right? Because the diminished calcium level in your urine either means that you have FHH, familial hypocalciuric hypercalcemia, and you don't have hyperparathyroidism, or it means your calcium absorption or consumption is too low. Some people have celiac disease and may have problems with absorbing calcium. Some people have had gastric bypass surgery, which may make it difficult for them to have absorption of calcium. So all those things are factors, right? So once you have all that information and you know for certain that you, based on the biochemical makeup of your calcium dynamic in your body, that you have hyperparathyroidism, then what you need to do after that point is, yes, the scans to see if there is another parathyroid that clearly is enlarged, it's not in the normal place, you're looking for an ectopic, right? Somewhere else that you can go into and remove. And if not, then potentially your surgeon may have to go back in and re-explore those remaining parathyroids that hopefully they saw during the first surgery. You say that they saw a third gland that looked potentially hyperplastic, but they didn't remove. You know, focusing on that area, definitely do it with intraoperative PTH testing, because you need to know what the status of your surgery is, what the success is, and what's the functionality of the parathyroid that remains behind. That's really important, okay? Hopefully that's helpful. It's a terrible situation to be in, Lisa. I'm happy to help you, and I'm happy to look at your numbers and try to help you in any which way I can, okay? Obviously, you know, there's a lot more information that needs to be found in order to answer that. Ronald Curtis. At the last Q&A session you felt, based on my calcium PT values over a year and given my normal vitamin D, that I had PHPT even though my calcium had never been abnormal, and you suggested having a 4D CT scan to confirm otherwise, the findings of an ultrasound scan indicating a possible adenoma. Based on your advice, I consulted a new endocrinologist who has agreed to do a 4D CT scan with contrast, though he does not feel that I have PHPT given the normal serum calcium, normal bone density, and low urine calcium. In fact, he feels that the biochemical results suggest I probably have FHH because 24-hour urine test this month has returned calcium creatinine clearance ratio of 0.0019. Yet, a similar test ratio in October returned as 0.00, and the end of the time discounted FHH even though the ratio was less than 0.01. I found the big disparity in the results very strange, and I wonder whether one of these tests is in error. Anyway, FHH is symptomless, I believe, and would not account for my clinical symptoms of hoarseness, malaise, tiredness, myalgia, and fragmented sleep. The endo doesn't believe the PHPT would account for these symptoms either. Hopefully the CT scan will show some light on whether the adenoma is present, but meanwhile, I have two questions today regarding symptoms. In PHPT, can tiredness have a sort of circadian pattern, whereby it's worse in the earlier part of the day? That's a very good question. As a whole, our body has a circadian rhythm, so I think even that can be impacted by that. But generally speaking, most parathyroid patients complain that their fatigue is all day long unless they're distracted and they're busy working and that don't realize it. Can intermittent hoarseness be a symptom of primary hyperparathyroidism? It can be, but it's not caused by the parathyroid gland itself or the elevated calcium directly. It's caused by acid reflux coming onto the vocal cords and causing them to swell up intermittently. Is the high calcium or the high PTH hormone, which makes people feel both can. Elevated calcium in and of itself can impede functionality of nerves and all the organ systems, but PTH can act like a neurotransmitter in the brain and cause problems there. It's also present in the cartilage of the joints, so some of the joint issues may be as a consequence directly of PTH. So both of them can work in concert to give you trouble. Listen, if you have a lack of clarity in terms of FHH, then you should do genetic testing to see it, because the genetic test is more accurate than the 24-hour urine calcium and creatinine clearance, right? And so I think the next step for you is to do a genetic test to rule out FHH. And if that test shows that you have FHH, then you have to look at other possibilities for your symptoms, as well as still keeping them in mind that even someone who has FHH can develop hyperparathyroidism. The parathyroid tumors don't discriminate, They don't only pick people who don't have FHH. It can happen concurrently. It's just really rare to have two rare diseases, right? In the same person, but it's possible, right? So keep that in mind. Try to do the testing. If you're not able to do the testing, one thing you may want to do is actually increase calcium intake with vitamin D and see if that affects your 24-hour urine calcium. Because if you have FHH, it probably won't impact the 24-hour urine calcium much. But if you don't, and what you have is a malabsorption of calcium, and that's why your parathyroid gland is overworking, then your 24-hour urine calcium can rise up, right? Those are the two different strategies I would suggest taking. All right. Lala. Oh, and this. I'm 58, my sister is 62. 3 years ago, she had a single adenoma removed. She had very minimal bone pain. I had 3-gland hyperplasia. Surgeon diagnosed it as familial isolated. Surgeon diagnosed it as familial isolated. An endocrinologist insists she believes hyperparathyroidism. She said if I wanted to waste money doing genetic counseling, I could. Two sisters in the same family having hyperparathyroidism means there's a genetic base to it, or both of you were radiated, right? Now, the reason to do the genetic testing is not that it's going to change your particular life or your sister's life, right? You guys have already been impacted by this disease. It is going to impact your other siblings and children, you and your siblings' children, right? Because if the gene is there, and it's one of the genes that we know that causes it, and you're able to identify it in a genetic test, then you're able to let your children know that they potentially have that gene, carry that gene, and they should watch out for this disease and not let it get to osteoporosis and kidney stones and all sorts of things like that. Act on it early if it starts to show its ugly head, right? And if it doesn't, just because people have some of the genes for hyperparathyroidism, it doesn't necessarily mean that they will all get hyperparathyroidism, right? It's not for certain genes like the MEN genes, there is a high degree of occurrence. For some of the other genes, the degree of occurrence, or we call it penetrance, is not 100%. So some genes, the degree of penetrance is 30%, meaning only 30% of the people who have that gene will get it. So not every person will get it, so you just have to kind of keep it in the sphere in your mind that this is a possibility. If you have symptoms, you let your children know. If you have symptoms, please look into it. Don't let your GP dismiss a slightly elevated calcium, so on and so forth, okay? So I don't think it's a waste of money. I think information is power. for you, it gives you a capability to pass on to generations an insight that would be valuable to them. So that's my thought on it. All right. Sorry, I keep coming to the side. I need to read the screen. My other computer is not working so well. Anyways, D. Owen Paxton. I would like to ask, what monitoring blood tests should we have and frequently? D. I answered this earlier in the thing, so please look back. But again, definitely for a parathyroid adenoma at 1 month, calcium PTH and vitamin D, and 6 months and annually thereafter. For hyperplasia, 1 week after surgery, 1 month after surgery, 6 months after surgery, and annually thereafter. Okay? Thyroid warrior, not warrior. I like that. Hello, Dr. Larian. My level in May were PTH of 14.9, calcium of 2.6, 3 to 2.66. So I'm assuming you're calling from you're worrying from the UK, and these are the UK system. So the units, both the calcium is either high, normal, or elevated, and PTH clearly high. Urine creatinine is 0.83, which is good, which is on the low side, I think. Vitamin D depleted at 33, now corrected to 101. Refer to sesame scan to see a surgeon. I'm feeling pretty unwell. My endocrinologist said I have mildly raised calcium and not to expect my symptoms to disappear with surgery. I have diagnosis of primary hyperparathyroidism. Do my levels warrant surgery? I'm worried that the scan will not show up anything, and my surgeon might be dismissive because of my endo's comment. You have an appropriate amount of concern, and I like the title you've given yourself. Listen, I would not start by doing a sesame scan. I would definitely start by doing an ultrasound. For people whose PTHs are not dramatically high, right? The sesame scan does not have a high success rate in finding abnormal gland. And so you're not, again, the scans are not there to give you a diagnosis. The scans are there to locate the abnormal gland so your surgeon can focus on the abnormal gland and do a pinpoint surgery or a minimally invasive surgery. Minimally invasive surgery meaning not a small incision, but rather being less invasive under the surface. That's the whole importance of minimally invasive surgery is being minimalistic under the surface, right? And so the sesame scan is not there to diagnose you. So a negative scan should not vindicate your endocrinologist that, oh, you're great and you shouldn't have this surgery, right? It just says that the abnormal gland was not found, either because the amount of PTH production is not high enough for the scan to detect it, or you have hyperplasia of all 4 glands and they're all slightly bigger than they should be and not visible on a scan. But the sesame scan is not an ideal scan in my mind. I would start with an ultrasound that has no radiation exposure, and if that fails, I would do a 4D parathyroid CT scan. Those have a higher likelihood of finding an abnormal gland than a sesame scan, in my experience, right? Now, there's some centers that do a better job at it than others, but in generality, that's been my experience. And you don't diagnose hyperparathyroidism based on scans, you diagnose it based on blood tests, right? Now, the next thing, the decision to have surgery. The decision to have surgery, it is not your endocrinologist's decision, it is yours, first and foremost. That decision is based on how much of an impact this disease has on your life, right? And how young are you? And what kind of a physical state you're in, right? If you're 85 years old and you're totally otherwise healthy and robust and doing well, and now you're seeing thinning of your bones and you have bone pain, yeah, you may not have osteoporosis yet, but you're in transition towards it, then yes, you should have it. But if you're 60 years old and you've had a heart transplant and you have lung disease on top of it, and you have slight fatigue, and that's the only symptom you have, it's hard to tell if it's from the heart and lungs or is it from hyperparathyroidism, then maybe not in the big picture, the right thing to do. All right. Thyroid Warrior says, thank you so much for your advice. I should have mentioned I had a total thyroidectomy 20 years ago also. Warrior, the total thyroidectomy is a blessing and a problem at the same time. It's a blessing in the sense that it's not hiding any parathyroids, and it may make a sesame scan more likely to show something, right? But sesame is a study of function, right? And so it all has to do with the level of functioning of the parathyroid that's abnormal and overworking on the inside. So I still think the ultrasound, now that you don't have the thyroid covering that area, could potentially show you. And he or she writes that I'm 51 years young, so you're young. You know, the consensus group guidelines, that is, if you're under the age of 50, you should go ahead and do surgery, right? So now you're 51 and you passed the deadline. I mean, like, that age group of 50 was very arbitrary, right? It's based on life expectancy data of the 1960s, and as you all know, our life expectancy is very much different, and quality of life is very much different, right? And so, now that I just turned 50, I have to say you're exceedingly young, and you shouldn't pay attention to that. And I personally would not want to have hyperparathyroidism for the remaining, whatever, let's say 30 years of life expectancy that we all have at the age of 50, right? 30, 35 years, probably even more. I would want to have this disease with me causing issues. Now, your doctor may be right in talking about the fact that the surgery may not take away the symptoms, but there's no study showing that doing surgery, if it doesn't take your symptoms, may not stop or halt the progression of symptoms, right? And that's meaningful in and of itself, right? And so I still think you're young enough where if you're having symptoms or if you're being impacted by this disease, you should have surgery. The International Consensus Group guidelines, which are also called the NIH guidelines, those guidelines say that if you're asymptomatic and under the age of 50, you should have surgery, right? You're 51 and you have symptoms. It's a no-brainer. Will all your symptoms get better? No one can tell you that answer, right? And they may not, but can it stop the progression of disease and development of more symptoms? Definitely. That can definitely happen. So I think you should make the decision yourself about what is the right choice for you, all right? Okay. All right, moving on. Janet Handley, thank you so much for your time. My pleasure. I'm in the UK and have had failed up due to an ectopic gland. Blood PTH are 23 to 25. Upper range of normal 7.6. Calcium is 2.72 and 2.77. Again, very elevated. Vitamin D deficient despite considerable supplementation, which occurs in hyperparathyroidism. 3 experienced surgeons in my neck for 3.5 to 5 hours and did a thymectomy, looked in the retroesophageal space and behind the sheath. I had 4 gland exploration and intra-PTH. PTH never went down. The left superior gland was not found. How useful are 4D CT and colon PETs in locating ectopic glands? Very useful, Janet. You're in the UK and you have access to both. I would do both before embarking on another surgery. What should I do if the rogue can't be found? Should I rush into 4D CT just 9 weeks after such an extensive operation? No. I would wait a little. I know you're in a rush. Give it 6 months. Let everything settle. You want to have the best shot at finding this thing, okay? And I know it's hard to tolerate the symptoms for a lot more time, but wait 6 months before redoing it, okay? because you don't want to have any false results, false positive results, right? False negative also, but false positive, and jump into a surgery when the scan is showing something that may be inflamed lymph node that has now more blood flow, looking like a parathyroid, okay? So it's too early for a repeat scan. Definitely wait at least 6 months prior to your next surgery before doing the 4D CT scan. If that scan doesn't clearly show it, I would proceed with doing a choline PET. And I know that Dr. Palazzo's facility in London does do the choline PET scan, so you definitely have that option of getting it, and I would exercise that. We have a much harder time, ironically, in the US getting a choline PET scan than you guys in the UK, so take advantage of that, please. And best of luck. All right, Sarah Whitney. What are the chances from a negative ultrasound 4D CT scan says to me that I have four-gland hyperplasia? Fairly high. I wouldn't say 100%, right? But it's substantial, you know, probably upwards of 30-40% chance that you have hyperplasia. Does hyperplasia usually have a genetic cause? If you don't have kidney failure, if you haven't taken lithium for a period of time, if you're not on medications that secondarily would cause hyperplasia, if you don't have chronic low vitamin D levels that have not responded to correction, right? And we've ruled out the other possibilities, then most likely there's a genetic base to it, right? Because when we say four-gland hyperplasia, we mean all four glands, all the cells within all four glands being abnormal. So each gland has roughly 5 million cells in it, right? So for 20 million cells to all be abnormal in someone who has parathyroid hyperplasia, then there must be some genetic base to all the cells having an abnormality. It's unlikely that all 20 million cells become abnormal together at the same time, right? So there has to be a genetic base, either a strong genetic base which could cause all of the cells to become abnormal and have been abnormal for a long time, or instead of having, let's say, if you need 4 mutations to get parathyroid abnormality, you have 2 of them, and so a great number of the cells in all the parathyroids become abnormal with toxin exposure in your lifetime. All right, those are the ideas. 3, is it reasonable to wait for genetic testing before scheduling a patient for surgery? This is the approach my surgeon is taking with me. By the way, my adjusted calcium is 2.93, unadjusted 3.06, PTH is 17, and vitamin D 20. I should add I have a sibling who had 2 parathyroids removed after a kidney stone when he was 14, although he had no further problems in the last 40 years, fortunately. And a cheeky 4th question. Given this level of calcium, should I be taking cinacalcet given that genetic testing is not likely to be back for another 8 to 10 weeks? One of the best sayings that I've ever heard for hyperparathyroidism is the best way to find an abnormal parathyroid is find an expert surgeon to do your parathyroid surgery, right? And that's the best advice I can give you, right? Let's just exercise what you're going through. If you wait for the genetic testing, right? And let's say the genetic test is positive, it makes it more likely, not 100%, but more likely that you have hyperplasia. All right, good. Well, having all these scans be negative, already the chance of you having hyperplasia, if I was your surgeon and operating on you, my degree of suspicion of you having hyperplasia is already higher, right? So I already feel like you have hyperplasia. I would go in the operating room, and if I see one gland that's enlarged and remove it, and if your PTH comes down exactly 50%, I wouldn't be enough. I would need your PTH to come down significantly more than 50% to warrant me not looking at your other glands, right? So that's me going in with a high degree of suspicion, right? If your genetic test is negative, I would again do the same surgery. I would go in there with a high degree of suspicion. You have a family member who had hyperparathyroidism and had surgery for it. you have scans that are negative, right? And so my degree of suspicion for hyperplasia is higher. Now, obviously, I would actually look at your scans with my own eyes and try to see if I find something that a radiologist may not see, and that does occur, right? But I would be highly suspicious of you having a potential hyperplasia state, even if you had a negative genetic test. All right, Sally JP. Hello, Dr. Larian. I've sent you this link by email rather than take up your time, but we would very much appreciate your thoughts regarding day 1 post-operative hypomagnesemia and whether magnesium should be tested as a routine both pre and post-op, please, as discussed in this link. Listen, I saw your email and I responded. Sally, I give my patients magnesium in the post-operative setting, all of them, all right? And I don't check their magnesium levels, right? I give it to them anyways. There is a strong association between low magnesium levels and hyperparathyroid patients and the postoperative state. There's also a mechanism where magnesium affects the calcium sensing receptor on the surface of the parathyroid glands. So as you're recovering, you want to not have an external factor impact your parathyroid cells, and magnesium has that impact. So that impact needs to be removed. And so I not only check it as part of the preoperative diagnosis of patients, but I also check it as I also deplete it and give supplementation to prevent an impact postoperatively. I don't check it, I actually just give it to the patients. I actually give a bottle of magnesium to every single parathyroid patient that I operate on. I think it's very helpful and it keeps people out of trouble. And I have found that by doing so, less many patients go into the low calcium states that can happen in the post-operative parathyroid state. Lala. Okay. Dr. Larian, thank you in advance for being here for us. My pleasure, Lala. Had 3 glands, hyperplasia removed June 10th. Calcium dropped to 9.7. Others, 20. Not sure I understand. Immediately, bone pain was gone. My anxiety was horrific, still is, but I'm prone to health anxiety. I had a month of tremor episodes. One doctor said it was body adjusting, most likely, and most doctors believe panic attacks. Anyway, had a few labs of calcium at 10.3, but others have stayed between 17 to 25. Still a lot of fatigue. Doctors again blame anxiety. A few weeks back, I woke up to a horrible leg cramp, and the bone pain, muscle pain has returned. Also, crashing fatigue. Endocrinologist and doctor insists it's anxiety fibromyalgia. My vitamin D has gone from 47 to 2 weeks post-op down to 226. Endo surgeon told me do not take more than 1,000 units per day because my calcium tends to go high. I'm so lost. On top of this, I have developed sleep apnea post-op. I may have always had it, but since surgery, I wake gasping for air. Surgeon and field surgery was fine and due to numbers. Neither is concerned at the moment of a calcium over 10. Our Facebook support group is the only thinking keeping me positive right now. I lack patience and wonder what I can do. Lada, you need to give me the parameters of your labs so I can see and what you mean by others. Listen, I can't tell by what you're presenting what's happening with you, okay? And I know you and I have spoken before. Shoot me an email, kind of graph me out what your numbers were before, calcium, PTH, vitamin D, magnesium, all the other things before surgery, and what they are after surgery, so that way I can try to figure out what's happening for you, okay, dear? I could be more helpful that way. Miss Bellas says, doctors can't find my parathyroids. What can I do? Thanks from Spain. Isabelas from Instagram from Spain. It's a complicated question, really, more so than you think. If they've done an ultrasound that's negative, a sestamibi scan that's negative, and a 4D parathyroid CT scan that's negative, the only other scan left is a choline PET scan, which I'm not sure what the availability is in Spain. I know it is available in the UK. And so, so that may be the other option to exercise. Again, if Isabella's, your number are elevated and clearly show hyperparathyroidism, you either have an adenoma that's hiding somewhere and that's not visible, or you have hyperplasia, which means all 4 glands are abnormal and they're all slightly enlarged and may never show up on a scan, right? And if your numbers are high enough and you've done all these 4 scans and they're all negative, if you're having symptoms, right, then I would say that you should proceed with surgery, and probably you have hyperplasia at that point, right? But I would try to do everything I can to get information with scans and everything else before I make that leap, okay? Lala's asking, how do I email? If you go to my website, parathyroidmd.com, parathyroidmd.com, there'll be a link for you to contact me, and then you can send your info, and then my staff will get on it with you and communicate everything. Okay, my dear? All right, let's see. There's some questions that came in as we were speaking. Let me see if I can answer them. All right, Shannon Taylor, do you have a limit of the dose of prednisone for someone with an autoimmune disorder that requires parathyroidectomy? I don't. You know, usually, if possible to taper down, we would taper down if it's possible, and then use a stress dose of steroids during surgery. But it's not an absolute necessity. Lisa Gonzalez is asking, for what specific reason would you have your patients genetically test for MEN1? If you're asking MEN1 specifically, is if they have a family history, or if they have tumors in other parts. With MEN1, it's pituitary and pancreatic tumors, right, along with parathyroid issues. But other MENs exist, MEN2 and 2A and 2B. You know, they also have parathyroid issues associated with them, and so. Especially MEN2A, so it all depends on what you have. But if someone comes in with parathyroid hyperplasia, especially if they have a family history of hyperparathyroidism, I would check for MENs, because just like Marianne, who was on this trail, you may not know that you're carrying that gene, and you may have family members that are affected. Just like Marianne found in the Netherlands, after we did the surgery and we suggested that she do the genetic testing, and then she found it in other family members and children, you know. So that would be the reasoning for it. Melissa Santana, my calcium is 10.3, PTH of 102. I have parathyroid adenoma. Is this yes? And if you, calcium 10.3 and a PTH of 102, you know, when you have secondary hyperparathyroidism, again, either that's from kidney failure, right, which would give you the same numbers and even higher numbers, or it's from vitamin D deficiency, in which case usually what the person gets is an elevation in PTH and not necessarily an elevation in calcium, right? So, you know, if your vitamin D levels are close to normal or in the normal, then you definitely have primary hyperparathyroidism. John Feeney, thank you for the compliment. Melissa Santana, calcium is 10.3, PTH 102, vitamin D is 34, yes. should I be taking calcium and vitamin D, or is this primary? If this is primary hyperparathyroidism, and you, if symptomatic, you definitely need surgery. Melissa, best of luck. My advice to you is find an expert parathyroid surgeon at this point. So Janet Hadley says, thank you so much for your time. I am in the UK and have had a failed op due to an ectopic gland. PTH is 23. We already went through this. Yes. Okay. Yeah. So yes, Janet, please wait 6 months before you do your scans again. Michael Melvin, hi Babak. If I had surgery 2 months ago and my pre-surgery numbers were calcium of 10.4 and PTH of 37, and after surgery my calcium is 10.2 and PTH is 24, is this cause for concern? Can it take time for things? Yes, it can take time for things to come down. I'd say I'm not alarmed, but I have my antennas up, right? And I will continue to monitor your numbers. I would repeat your blood test in 2 months and again at 6 months and see what those numbers do. There are times that these numbers take a bit longer to normalize, okay? But keep an eye out. Allison, my pleasure, Allison. Anything I can do to help you, I will always do, all right? Lisa Olson, this is so interesting. Thank you for taking the time to explain this. I've had a double parathyroidectomy, which I feel has failed. Post-histology states hyperplasia and hyperplasia on the right nodule, as well as previous surgeons stating that there were signs of a third growth on the third gland. Nearly 2 years on, I have within normal range calcium at last test, but have consistently with PTH. PTH is 84. Calcium is creeping up. I've taken oral vitamin D spray, good job, and my PTH has not come down even with vitamin D. So, you know, in the UK, you guys had you had a guidelines set for treatment of parathyroids. Let me remember what the name of those guidelines were. Let me bring that up. They were the NICE guidelines, NICE guidelines. And the NICE guidelines addressed who should have treatment, you know, and it carefully skirted around the subject of normal calcemic hyperparathyroidism, right? And I spoke with Dr. Palazzo about it, and he said, yeah, that it is a touchy subject. There are reports showing that normal calcemic patients, when you operate on them, they don't get better. A lot of parathyroid surgeons shy away from doing that, and that's probably the reason you're having a hard time. But I would say if you have deep symptoms, right, then you really need to take action. You know, if they took 2 parathyroids, they saw under the microscope that you have hyperplasia, you know you have hyperparathyroidism and parathyroid hyperplasia. Treatment of parathyroid hyperplasia is not 2 gland removal. It's either 3 or 3.5 gland removal. So you did not have an adequate surgery, right? You just need to sit down and have a heart-to-heart with your surgeon, stating that you understand that there's a possibility that your symptoms will not get better, but you are willing to take the risk of that, right? If you are willing to take the risk, you are willing to take the risk of that. And I would do it with your original surgeon, right? Because if that original surgeon was an expert surgeon in parathyroid surgery, they'll have the best shot at doing a revision surgery for you. In any case, let them know that you are willing to take the risks of having a repeat surgery, all the inherent risks with it, all right? And tell them how much of a surgery you would want them to do. Would you like them to do 3 gland, remove third gland, or 3.5? If your surgeon is not doing intraoperative PTH, right, for a revision surgery, then I wouldn't do it. I would do it with someone who's doing the intraoperative PTH for revision surgeries. I know in the UK, again, based on the NICE guidelines, they decided that doing routine PTH testing in all patients doesn't make sense. It only helps a small percentage of patients, which is true. It only helps a small percentage of fresh cases, not revision. Revision cases is vital, right? It changes the plan, fortunately, in a small number of cases, right? Because it's a small number of cases that have double adenomas that are not clear based on preoperative scans, right? So, but you know, you have a revision situation, you need intraoperative PTH, you need to have the situation addressed appropriately and adequately, right? So, you know, just have a heart-to-heart with your surgeon. That's the best I can tell you. Can someone tell me what order Dr. Larian is reading our questions? Are there questions we posted last week? Yes, they are, Labelle. They're questions that were posted last week. I'm just going in order. Karen Constance Carter. Dr. Larian, can a parathyroid tumor near your windpipe cause breathing difficulty? I've never seen it happen in the past 18 years that I've been in practice and doing parathyroid surgery myself. They just don't grow large enough, and they're not hard enough to push on the windpipe. The windpipe is made up of cartilage. It's real. I mean, when I'm in the person's neck, even if I try to compress the breathing tube, it would be hard for me to do it with my hand, right? It's not easy. So a parathyroid tumor doing that is not very likely. Holly Supa, I had a redo surgery to have a second parathyroid removed the size of a marble. PTH dropped from 98 before surgery to 21 in the OR. Great. Surgery was 2 weeks ago, tomorrow on August 5th. When do you typically start feeling better? I'm still having headaches, dry mouth, increased urination, joint aches. I'm very anxious. My sister also had been found to have hyperparathyroidism. A hard question to answer. The bone pain is the thing that goes away quickly, usually almost in the recovery room, but the remaining symptoms take a long time. And I always tell the patients the amount of time it takes for you to get better from your symptoms has to do with 2 factors that I've noticed, and that is how much higher calcium is from your particular normal calcium, right? So your preoperative calcium to your postoperative calcium, and how long have you been in that state, and how high was your PTH? The higher the PTH, the more symptoms. You know, the higher the level of difference between your calcium and your hormones to your particular normal, and the longer that has been in place requires your body to make adaptations and adjustments for a longer period of time. When your body makes an adaptation to adjust to a higher level of calcium, that means your body has changed itself to adjust for that abnormality in your body. When you correct that, right, if you've had hyperparathyroidism for 2 months and you now are correcting it, your body can make corrections very quickly. But if you've had it for 12 years and your body has made 12 years worth of adaptations in multiple organ systems, right, that now have to adapt not only to a higher calcium but to an organ system that has adapted to a higher calcium, and they have to function together now, that means they've adapted not only to the calcium but also to each other's new normals. When they have to make a new adjustment, it definitely take long. So when you read these accounts online of people saying, I had surgery and I feel like $1 million, I feel 1,000 times better immediately, right? Those are the exceptions, unfortunately, I would say. Most people take a long time, because most people take a long time before they discover they have this disease, right? Most people are led down a path oh, this is a disease of middle-aged women, right? Most often happens in that demographic. So these poor women are being told on a constant basis, oh, you're going through hormonal changes, which is actually true. They're just talking about the wrong hormones. They're talking about the female hormones rather than parathyroid, right? And that's it. You're anxious, you have anxiety, you have depression, you have fibromyalgia, you have chronic fatigue syndrome. All these boxes that they put these poor women in, right? And so that's why it takes longer for them to get a diagnosis. You see me getting angry because it's just, I hate people getting put into boxes rather than being. Let's see. Ashley West Leonard, have you ever treated hyperparathyroidism in someone who has been diagnosed with ALS? I have not. Oh, that's a good question. Ashley, that is a very tough situation, okay? I would say this is rare in ALS, meaning ALS that moves slowly is a person who potentially can benefit from doing a parathyroid surgery, especially if the scan shows where the parathyroid is. You can potentially do the surgery under local anesthesia with minimal disturbance of the body, minimal impact, negative impact on the body, and it can potentially help. I have not done this surgery. All the patients that I've had ALS and hyperparathyroidism have had rapid progression of their disease, and so I didn't think it was the benefits of doing the surgery and exposing that person to anesthesia and things like that didn't seem worthwhile as compared to the potential harm that it could do. But if the disease progression is very slow, then entertaining the idea of doing parathyroid surgery is sensible, right? But that's the only setting I would say that would make sense. All right. Tammy Morella Hartenbauer. I just turned 60. My labs are borderline. Calcium is around 10 to 10.4. PTH has always been 50. My vitamin D is 30s. My tonifier uric calcium is normal. Reviewing my father's labs, I noticed his calcium was always the same numbers. He sees a cardiologist and nothing was ever mentioned to him. He's not had any other testing. He's 86 years old. Is it possible we will both just have this level of calcium and it's normal for us? Yes, it is possible. It is possible that you have that, but if that was the case, your PTH wouldn't always be in the mid-50s, right? So let me flip you around and explain to you what I'm trying to say. In a normal person, the way the parathyroid glands work is that on the surface of them there's a calcium receptor. When enough calcium elements attached to the receptor stop the gland from producing PTH. So those yellow dots were the PTH. And when there's no calcium, it starts releasing PTH and producing PTH and letting it out. Now the picture is not perfectly accurate. It's done for the sake of simplicity. But when you look at that dynamic on a graph, calcium, this is calcium, this is PTH. And the graph is like this. So when you look at the inflection point, we call it a calcium set point, right? So when the curve gets to its halfway point and changes angulation and direction, we call it a set point, right? Everybody has a genetic set point. So for this person, that set point is 9.5. When the calcium goes from 9.5 to 9.4, the PTH shoots up by 30%, right? So that means the PTH goes up by 30% when the calcium goes from 9.5 to 9.4, right? And then when the calcium goes from 9.5 to 9.6, the PTH drops by 30%, right? And so there is a variability that exists, right? So when you have, in looking at your numbers yourself, you have to see if your calcium is at 10.3 and your PTH, let's say, is 55. When your calcium goes to 10.4, does your PTH go down to 50? And when your calcium goes to 10.2, does your PTH go up to 60? If you have this variability, then yes, your body wants a calcium of 10.3. Your set point is 10.3, right? And if you look at it at more data points in time, you may find that the numbers of PTH varies more widely than just 50s, right? Because again, when you look at this person here, there are times when this person's calcium went down from 9.5 to 9.0, and the PTH shot up to a really high number. And there are times the calcium goes up to 10.0 and PTH goes down to a very low number. And that's a normal. That is a normal person, right? And so if you have wide variability in your PTH and it looks appropriate as a response to calcium changes, then you're normal, and that's your normal. And what you have is a curve. Your curve sits here with an inflection point like this. This is your calcium set point at 10.2 or 10.3. You're normal. That's where you exist. You and your father have that same number, right? But your numbers that you're presenting is not showing a wide variability. So I am concerned. I would say you need more of an investigation. Okay? Let's see. Pamela Newsom, I finally had a doctor who will commit to helping me. Hallelujah, Pamela. I'm very happy. Holly Supa, my first parathyroid removed 6 months ago came back as consistent with an adenoma. Just had another removed due to continued elevated calcium, 10.3 PTH. That one came back as hypercellular parathyroid tissue. PTH came down from 90 to inolec. Is this considered a double adenoma, or could I have hyperplasia? Holly, let me explain. So, okay. So, sorry, you were looking at my ear. Here you go. So, a normal parathyroid has roughly half these pink parathyroid cells and half these clear fat cells, roughly. Now, mine may be 60% fat and 40% parathyroid cells, and yours may be 60% parathyroid cells and 40% fat, right? But roughly around the number, right? And as the parathyroid disease continues, you get more cells and less fat, right? So this is a hyperplastic parathyroid gland. I'm sorry, not hyperplastic, a hypercellular parathyroid gland. It has more cells than fat as compared to this one, right? The only way you can tell if a hypercellular parathyroid gland is an adenoma is if you see a densely cellular parathyroid. These are blood vessels, right? And this is a little bit of fat here, right? And not much fat anywhere else. A little bit there, a little bit there, right? Mostly cells. And then this parathyroid has, very importantly, a rim of normal parathyroid with half cells and half fat, right? Arrows pointing to it. This person, you can tell with confidence they have a parathyroid adenoma, right? But if the specimen was, instead of being cut in this orientation, was cut in this orientation where it misses the parathyroid, and you're looking at this area, right, misses the normal parathyroid, then they would say this person has a hypercellular parathyroid gland, right, and potentially hyperplasia. So, in answering your question, Holly, I can't tell you, right, because it really depends on how the pathologist viewed the specimen, right? I can't say the second gland that they took out is an adenoma, or if the second gland shows hyperplasia. They did do all the cuts in all the orientations and there was no rim of normal. I can't say that because I don't know what the pathologist did, right? But if they did do that and they didn't see a rim, right? Or if they cut it this way, they could entirely miss the rim, right? Even if they cut it, let's see, if they cut it right at the edge and they see a little bit there, they may not be enough because actually they could get the denser part there than the less dense part. So I'm saying prone to problems. Parathyroid pathology reports are prone to problems. Okay, so what's going to give you more of an answer is what your calcium pH numbers do in the future. If they continue to do well, then you have two adenomas, which does occur in 11% of people. And if the numbers creep up, then I would say that probably you have a background of hyperplasia and you had an adenoma growing in it, right? Now, I have seen pathologists not see the rim and call it a parathyroid adenoma, right? So I don't know if your first parathyroid was an adenoma. I would ask my surgeon to look and see if there was a rim of normal, which is the reason why your doctor said, oh, it was an adenoma, okay? Joe Carol Hughes, I have hyperplasia, 2 surgeries not yet cured. Could taking lithium for 5 years have caused? Yes. Unfortunately, lithium is a cause of it. Majority of the cases of patients who've taken lithium for a long time develop hyperplasia, but some develop adenoma. So I'm sorry you've had 2 surgeries that have failed, but you know, you may consider using cinacalcet, or the other name is Sensipar, to see that brings your numbers down if your surgeons are not able to find the other parathyroids, to see if that gives you improvement in symptoms, okay? Chris Hopshaw, thank you very much for these sessions. Dr. Ali, you are the true gem. I'm so happy to have had my surgery with you. Chris, my pleasure, lovely. Thank you for the compliments. Good morning, Dr. Larian. This is Annie Taylor. I have 1 kidney. The other was removed due to kidney cancer, which was discovered due to a kidney stone. Luckily, I passed the stone without knowing. I'm reluctant to take any additives in the case they have negative effects on my remaining kidney. My GFR is 67. I've been diagnosed with hyperparathyroidism. I'm not guessing the kidney stone was due to this. The last blood test earlier this year, calcium 2.83, PTH 11.3, okay. Vitamin D is in normal range. I don't actually know the figure. My question is it safe for me to be taking magnesium when I do have this surgery? Many thanks for your time. I find nephrologists to be exceedingly intelligent. Some of the brightest doctors actually end up becoming kidney specialists, because kidney doctors are always thinking numbers and values and making adjustments. And so I would ask my kidney doctor, right? Because if your magnesium levels have been normal prior to surgery, right, and your kidney function in the remaining kidney is somewhat compromised, your nephrologist is the best person to tell you if your kidney is able to tolerate taking magnesium after surgery or not. I don't think taking magnesium is an absolute necessity, But we fortunately have blood tests. We can test your blood and we can adjust your magnesium intake accordingly. So you're not committed to a one-size-fits-all post-operative management. We can adjust based on your needs, your particular needs and desires, all right? Ashley West Leonard says, yes, it is an atypical, slow progressing type of ALS. Then Ashley, listen, if you do scans and you find an abnormal parathyroid that's enlarged, then doing the surgery under local anesthesia, right? Especially if you're thin and you have a thin, long neck, very doable. I do that all the time. It's actually my preferred way of doing the surgery, right? Very easy to do. It doesn't expose you to an immense amount of medications that could impact your ALS, and you have the potential of optimizing your muscles and your nerve function. I don't know if it'll make you better, but it may slow the progression of disease even more so. And hopefully that's the case. But I'm saying that as an uneducated person in this because there's just not enough experience with ALS. Francesca Delgadillo. Hello, Francesca. I had surgery 2 months ago. Post-op, my PTH was 8 and calcium 9.2. My PTH has been 84, 82, 134, 84. At 3, 4, 5 weeks. Okay, so at weeks 3, 4, 5, and 6 post-surgery, PTH has come up to 84, 82, 134, and 82, with calcium of 9.1, 9.1, 9.2, and 9.6. Is still within our normal post-op ranges. It's concerning, right? But it's possible that if your calcium is significantly lower than what you had prior to surgery, that these elevated PTH numbers reflect your body trying to rebalance and getting calcium. So bones hold 98% of the calcium in the body, right? So most of the calcium in your body is in your bones. And if you have hyperparathyroidism, especially for a prolonged period of time, that elevation in calcium comes from your bones because you're not taking extra calcium through your diet, causing calcium elevation. It's the PTH drawing calcium out of your bones. So your bones are actually depleted. So people who have hyperparathyroidism, even though the calcium in the bloodstream is too much, is high, that represents 1 to 2% of calcium, entire calcium in the body. 98% is in your bones. And your bones are depleted of calcium. So actually overall, you're low in calcium. Which is why I give calciums post-operatively, right? So if your calciums are low in your bones, and your bones are grabbing all the calcium out of your bloodstream and trying to bring the calcium down in your bloodstream in the process, your parathyroid gland would react by producing extra PTH to try to keep the calcium in the blood and not let it get too low, and that struggle would ensue. And you know, it can take 6 months, it can take up to a year for that PTH to normalize, right? So I think, again, your antenna should be up that the PTH is high, but it is not very unusual for this to happen. I would wait till the 6-month mark and test again to look at, see and how the numbers are affected, but I've seen it last up to a year. All right, very good. That takes care of all the questions. Best of luck to all of you. The fact that you're already here, you're asking questions, you're looking at the responses, it empowers you to make the right decision and to force your doctor to make the right decision for you, right? And so I'm happy if I'm able to at least empower you to help you make the decisions that are appropriate for you. All right. There's one last question that just came in by Terry B. My ultrasound showed two nodular areas, one seen previously 9 months ago and is now 2 millimeters larger. Technician stated correlates with parathyroid. Okay. Calcium is 9.5, PTH is 3.4, vitamin D2. What is my next step? Well, I would talk to your doctor and have them look at the ultrasound images, and you know, PTH of 3.4. I'm assuming you're not in the U.S. because the units are different. But if that is a high PTH number at a calcium of 9.5, and you've had that persistently, then you should take action. All right, Terry. And then Amy Lewis Fish. Let me look and see. Hold on 1 second, dear. Sally, Sarah, Janet, Thyroid. Amy, I don't have your question. Put it on the thing and I'll answer it. I'll send you an answer. All right, my dear. I won't skip you. I just don't see it on the list here for some reason. Send it to me again. All right. Anyways, best of luck, everyone. Take good care of yourself. We'll see you next month. Please be smart. Please be safe. Based on your questions, you guys are all very intelligent. So trust your own instincts. Bye now.